Good evening, everyone, and welcome to the fall edition of UHN Foundation's Behind the Scenes Lecture Series. My name is Christy Spencer, and I'm the Senior Director of Stewardship at UHN Foundation. I'm thrilled to be your MC tonight, and I'm very glad to be spending the next hour with you. UHN Foundation is committed to providing you with the most up-to-date information about our healthcare system, and this evening's presentation is a way for us to thank you, our incredible donors, for your continued generosity and support. Our clinicians would not be able to lead world-class healthcare without you. Our behind-the-scenes lectures gives you a snapshot of some of the amazing work and innovation that is happening at our hospitals, and today's presentation is no exception. Innovations that are taking place in our hospitals empower people throughout our communities to live their best lives, and donors like you make that possible. Today, we are incredibly fortunate to have two visionaries from the emergency medicine team, Dr. Erin O'Connor and Deb Davies. They will share with us the latest innovations in emergency medicine at UHN. UHN's two emergency departments located at Toronto General and Toronto Western Hospitals are open every day and at every hour, available when we need them the most. Over the past few years, there has been transformational change to increase much needed access to care. Toronto General's emergency department has been expanded through the opening of the Michael Lawrence Turk Rapid Assessment Center. The health equity programs within emergency medicine improve patient outcomes and enhance their overall well-being. There has been a virtual transformation of emergency care through the Phone Connect and virtual emergency medicine program. And building the new Myrna Daniels Seniors Emergency Medicine Center will expand Toronto Western Hospital's emergency department and tailor emergency care for older adults. And I know our speakers will further touch upon some of these items in their presentation. So as our conversation unfolds today, if a question comes to mind, we'd love to hear from you. We invite you to submit your questions to our experts via Slido. There should be a link just below this screen to get you to our Slido page, and we will dedicate the last portion of this event for your questions. Now it gives me great pleasure to introduce Dr. Erin O'Connor and Deb Davies. Dr. O'Connor is the Deputy Medical Director of Emergency Medicine at UHN. She is a leader in emergency medicine, palliative care, and geriatric medicine, and we are thrilled she could be here today to give us an overview of what is happening within the emergency medicine program. Erin, give us a wave. Hi. Deb Davies is the nurse manager of the emergency medicine department at Toronto General Hospital. Deb has been with UHN for over 36 years and has been the absolute foundation of the team and the department. She was named Canada's Nursing Hero in 2020 by Hospital News for her vision and leadership. Dr. O'Connor and Deb, welcome. Over to you.
Thank you, Christy. We're so very happy to be here. So we'll get started with our presentation. Thank you so much for joining us today, everybody. We're so excited to tell you about all the amazing things that are happening in our emergency departments at UHN. And so we're going to talk a little bit about what we've already done, and then we're going to talk a little bit about what's next when it comes to our plans for how to transform our departments at UHN. So next slide. So wanted to tell you a little bit about the City Builders campaign. And this was really the campaign that was launched in September of 2019. And this was to help fund our new Rapid Assessment Center. And many of you actually may have experienced care in this center. It is big and it is beautiful and it is shiny new. When we originally launched this campaign, our goal was to raise $28.5 million to build this wonderful new space, and we did achieve that goal. We've opened the space now, and Deb will show you a little bit more about it, and we'll walk you through it. But we have received such wonderful feedback from our staff and from our patients. This is a space that's definitely dedicated to care, and the space itself lends itself well to healing, which is in contrast to some of our other spaces, which have gotten a little bit old and worn. This is a really lovely space. So we expanded the emergency department at Toronto General by 9,000 square feet. So we essentially doubled the size of the department with this. And this huge space replaced 5 rooms that we originally had before serving this population. And this project was fully funded through generous donations that came through our foundation and from donors like yourselves. So big thank you for that. Next slide. So our department at our emergency department at Toronto General Hospital was designed to care for 20,000 patients per year. And currently it cares for over 55,000 patients. So currently we were at least sorry, bursting at the seams. And we were noticing an annual increase of more than 7,500 patients at both sites. So we really needed some more space. Next. Emergency departments are really the safety net of the healthcare system. You know, we pride ourselves on being open 24 hours a day, 7 days a week, 365 days a year. We never sleep. We never turn away people. We are there for everybody. And this is something that is really core to the mandate of emergency medicine, that we are there when you need us, and we are there to help you on your worst days. We are at Toronto General and Toronto Western at provincial and national referral centers due to our specialized care. So we are, because of our transplant programs, because of our congenital cardiology programs, and our more advanced cardiology programs as well, because of our proximity to Princess Margaret, we are the emergency department that serves our cancer population at Princess Margaret. And so we not only see the usual things that come into an emergency department, the heart attacks, the strokes, the sprains and the breaks and the things that need stitching, but we also see very complex patients, some of them with very rare disorders. Some of our patients, you know, come in with their own descriptions of what their disease is because there are only 10 people in the world with that disease. And so we end up needing to work very closely with our patients so that we know how to care for them properly. So that's the type of really specialized care that we're providing in our EDs. In 2016, as we were bursting at the seams and growing so rapidly at Toronto General, we added 14 hallway spaces to our ED. It's not something that we wanted to do, but something that we were stuck with. And you've certainly heard of hallway medicine happening all over the country. This is something that we really had to do in order to keep up with the volumes. And this overcrowding, the use of these unconventional treatment spaces do persist. And when the pandemic hit, the COVID-19 pandemic, our care spaces were reduced by about 40%. And this was because of the need to keep people separate, to keep people distanced, because of the isolation requirements. And so our space was severely limited, and overcrowding and putting more people in the same rooms was no longer really an option. And it really highlighted also the need to support our vulnerable populations who have been disproportionately affected. So when it comes to the space being limited, it was really, you know, it highlighted the need for a rapid assessment center, and we were able to open this successfully. So that did relieve some of that burden. When it comes to highlighting the need for our support of our vulnerable populations, this is where things like the Phone Connect program came in. We had one of our docs early in the pandemic as we were trying to arrange follow-up for patients who were diagnosed with COVID-19, was getting frustrated actually that many of our patients who were being diagnosed were patients who were underhoused and did not have phones. So we had no way to follow them, no way to ensure that people were maintaining the quarantine that they needed, or that they were getting appropriate care and review of their symptoms to make sure that they didn't need further support. And so she did go to our medical director, Sam Saba, and said, I'm tired of people not being able to have follow-up simply because they can't afford phones. Is there something better that we can do? Can we give them phones? And she said, I'm going to look into this. And she did. And she ended up working with our foundation and a number of companies to have phones in our EDs that we can provide to patients who can't afford a phone and can't afford a phone plan, so that they can actually have their follow-up appointments, so that they can receive better care. And this is one of the ways that we're helping our populations that really need more than what our conventional care before could provide for them. Next. So you can see here, this we love this to show this slide, and I know this is one of Deb's favorites as well. So this is downtown Toronto, and in the blue there in the middle, you can see Toronto General Hospital, and all of the red are buildings that are slated to be built by 2030. So 350 new buildings and 650,000 new residents in the downtown core. And when you think about it, originally Toronto General Hospital was designed to be this tertiary care, which is the who the specialists refer to for further specialists. That's the type of center we have. But we really exist in a space where we need to serve our communities, where we have people living downtown and we are their local hospital. And so we've really had to adapt. And this is where the Rapid Assessment Center comes in. And I'll turn it over to Deb now.
Thanks, Erin. Just on to the next slide, please. So I'd like to start by giving you a little bit of a background on our emergency department, and Erin's touched on it a little tiny bit. We moved into the current space in the year 2000, and as Erin said, it was based on the population that we served at the time, predominantly our high acuity patients, those who had a previous history at Toronto General, and those who were affiliated with our unique programs. And although the new build from the year 2000 was originally designed with what they called a rapid assessment area, it had rooms specifically built for casting, eye exam, suturing, and so forth. It really wasn't the population that we were seeing at that time. It really only accounted for about 10% of the people that would have been suitable for those beds. What we really needed was space for our sicker patients. So all of those designated rooms were repurposed for our high acuity care. And our ambulatory patients, small numbers as they were seen in any available space. Then over time, we started to see a significant change in what was going on around our hospital. We started to see this increase in the residential growth, as you saw in Erin's slide. And our population also started to change with that. We would see an increase in the volume of patients who were coming in with lower acuity illness and those who had no access to primary care. Many of these people were young and lived in those new condos that were surrounding our local hospital area. We saw our volume go back from 2004, we were seeing only 70 patients a day, which for me now is hard to believe, to about 170 to 200 patients where we were pre-pandemic. And all of these patients were being seen in the little teeny tiny pink area that you see on this slide. So our space configuration was no longer suitable or adequate for the volume of patients that were coming through our doors. So between the years of about 2008 and the opening of our new Rapid Assessment Center, we tried a number of different strategies to manage our growing volume. What we did was we tried to reconfigure our existing space. We started with a 4-chair waiting room and 1 dedicated exam room that we would turn patients through. And we finally expanded to the yellow space that you see on this slide. That gave us 12 chairs in a waiting room, 6 exam rooms, and 4 hall beds. And you may not believe this, but we were seeing 45% of our volume in an area that was less than 2,000 square feet. Needless to say, that space was really cramped, really dark, really dreary, and we realized that this was not going to be sustainable moving forward. You only need to drive along Yonge Street at any time to realize that there continues to be a tremendous amount of planned residential growth in the area, and there's more and more spaces are being slated for development. We did know that we needed to find a space that could manage our growth that was also close to our existing department. And so for me, the space that made the most sense was the space that was occupied by admitting the surgical pre-admission area and the diagnostic test center, which you can see on this drawing in the blue. When I went over there, it had a beautiful big waiting room, had nice size exam rooms, it had a nursing station, and it was also close to the emergency department. So I thought, well, this would be a perfect spot for expansion. And I really thought we could make it work with a simple coat of paint and maybe some small modifications to the rooms to ensure good patient flow. But with the amazing work of our foundation and through the generosity of so many of our donors, we were given the opportunity to really rethink how we care for patients. And we had the incredible gift of being able to design a purpose-built space to meet the needs of our patients. And so our beautiful Rapid Assessment Center became a reality, and this has had such a positive impact on our patients and our team. We could go to the next slide, please. So in order to gain access to our new space, we needed to relocate and redevelop the admitting, pre-admission, and diagnostic test center. The first phase of this project was to move this team to their newly developed location. And if we could go to the next slide. So you can see here the space where our patients go in the hospital for their blood tests, their ECGs, their preoperative assessments, and to complete their admitting paperwork. Well, not paperwork anymore, it's all electronic with Epic. So this expansion and this generous donation not only benefited the patients coming to the emergency department, but it also has had an impact on patients from almost all programs at Toronto General who need blood work or a surgical admission. All of the spaces and rooms in this area have been configured with the potential for repurposing later as a patient care space in the future if we need it. We've made sure that all of the exam rooms were outfitted with medical gases, and they've been designed for active patient care. Our next slide shows you the old rapid assessment zone. And you can see how awful this is. You can see that the communication center in the middle is really, really tiny. And you can only imagine what it was like to work in that space with six or seven of your other colleagues all trying to do their work at the same time. It's not very appealing, it's very dark, and it's very small. On the next slide, you can see our new space. And just from the photo, you can see how much more inviting this area is for our patients and for our team. We have 2 communication centers where staff can sit while they're working and visualize the patients that are in the bays. There's also a working room in the back, and this area is for our providers where they can have some privacy when they're discussing patient care. The recliner bays are there for patients to receive treatment in a space that's functional and comfortable. They're all outfitted with oxygen and suction, and you can see how that wall of windows has opened up the space, making it feel less crowded. And it's like that even when the department is really busy. These windows look out onto an amazing green space, and all of the window openings can be controlled by the patient so they can let the light in if they choose. We have a number of exam rooms. There's 7. All of them are multi-purpose, so we can use the rooms for every single kind of procedure that we want to do. And this helps us improve patient flow through the area. Knowing that Epic was coming, we also had the ability to outfit each room with a computer, and this allows our team to document at the point of contact. One of the other benefits of the space is that we're now able to register patients in the area during our peak working time. So for this space, the peak would be between the hours of 11 a.m. and 11 p.m. And what this has done by being able to move the patients from triage straight to the registration, it's really reduced the bottlenecks that we experience in our main waiting room. On the next slide, you'll see the new waiting room space, and it's gone from 12 chairs to 20 spaces. And this really has made a difference for our team to manage the volume. We've cared for upwards of 40 patients at a time in this new area. And even when you have a volume like that, the space doesn't feel busy because it's just so wide open. Our staff have made a number of comments on how well organized the space is for patient care and that they have all the tools and resources they need to look after our patients. And the supplies are where they need them, when they need them. And that makes the work so much more efficient. We had that space was totally designed with input from the people who work in the area. They had a say in how to create a workspace that was organized and efficient. And I am a firm believer in the people that do the work know exactly what they need to get it done. And so input from this team has been critical to the success of this space. And on to the next slide. This all was happening and the design was all happening at the time that our pandemic started. So this was a terrific opportunity for us actually to take a look at what did we need and how could we build it out for future pandemics. So we had the ability to add 4 negative pressure rooms. The original plan was for 1 negative pressure room, but we've been able to add 4 negative pressure rooms isolated in an area isolated from the rest of the department and the rooms in the bays so that we can ensure that moving forward, should we ever require them, we have enough negative pressure rooms to care for patients with those high needs. Through another very generous donation, we were also able to create a bright and quiet space for our vulnerable patients who may need to wait to speak to a social worker in the morning. And you can see our beautiful respite room down on the bottom of this slide. Our patients have made lots of positive comments about how comfortable they are, how beautiful the space is, and for anybody that's been here before, how much different it is from the old space that we were occupying. And on a more personal note, I have to say that this space is far more than I could have ever imagined, and I am truly grateful to everybody that was involved in making this a dream a reality for our department. And now what we'd like to do is we'd like to share a little video that was made to give you a better sense of what this space means to our department. So could we go ahead with the video, please?
I love this team. This team is everything to me. This space will bring so much more positive energy for them working through a really hard 2 years.
I think the first time we heard about this new space, we thought it wasn't going to happen. It was too good to be true. It was kind of the magical land that was going to provide us with such amazing, dedicated space to do our work that it felt like it was never going to happen in our lifetime.
We've practiced so long in an area that feels the size of a postage stamp, and you're practically sitting on each other.
This space is definitely awesome, really spacious. It's definitely going to add a lot to the emergency department. A lot of our patients are ambulatory patients that could make use of all the space instead of being cramped up in our emergency as it is right now.
In 2008, we were seeing 85 patients a day. In 2019, that had moved up to 170 patients a day. So our volume for the space we were in before was way too high, and it's resulted in us having to manage patients in the hallway. We have our current rapid assessment zone. People are very crammed in. So having this 9,000 square feet to be able to have our patients have some privacy and a beautiful space with lovely windows that can let the daylight in, it's going to make the world of difference for our patients and the experience they have when they need to come to the hospital.
There's such a degree of moral distress when you have to take care of someone in a hallway, when you have to see an elderly person spend the night in a hallway that's busy and loud and the lights never go off. You take a little bit of that home with you every day, that level of distress that you experience. I'm very proud of our team. We have some of the best providers in the country. Extremely highly trained, very proficient, wonderful people. And I don't know that I could say the same about our infrastructure. But finally, now I can say we also have a department that we can be proud of to serve patients in an environment that is conducive to their healing and to a positive patient experience.
I just want to thank all of the donors who have made this beautiful space possible for our patients and our team. You will never know how grateful we are.
I want to thank all the donors for making this possible. I'm very grateful.
Thank you to the donors that made the space possible. Their contributions are really going to be a help to the patients and the staff moving forward.
So much joy in that video, and you can see really that has continued with our staff. People like to work in that space and to be in that space. And so moving from one transformative space to the next. So we were able to deliver on the rack in our lifetimes, and we're now working on our next project, which is one, again, that we weren't sure we were going to be able to make happen, but we are so excited about. And some of you may have heard about this. There was a big announcement about this a couple of weeks ago. We received an extraordinarily generous donation to create the Myrna Daniels Senior Emergency Medicine Center. Next slide. This will be housed at the Western, actually. We have to make it equal, of course. So we will be moving over there for this area. And really what we will be doing in this space is leading global transformation in emergency care of older adults. And this is not just a space that we're looking at, but really we are looking at an entire vision of changing the model of care for patients who are older. Next slide. This will be, we're moving on to the video. So just my apologies. So this will really be the first dedicated emergency department space in Canada that is purpose built for older adults, and the first program in the world that is comprehensive, that will be looking at excellence in the provision of care to older adults in an innovative physical space that has lights that are designed to minimize the amount of delirium that patients may develop, with noise reducing strategies, with floors that are designed so that people won't slip, with wider doors and wider washrooms so that people can get in and out if they're using wheelchairs or walkers. This space will be dedicated for people who have extra needs because of their medical conditions and because of their age in this space. And we are also looking at furthering emergency medicine research when it comes to management of seniors and their needs. We know their physiology is different. And also for teaching these skills to other providers, to other nurses, to other physicians, so that we can raise the bar for emergency medicine care across this country. Go ahead and start the video.
I came into the emergency department one morning at 7 and found an elderly couple in our hallway. The patient was the wife, and she was on the stretcher, and the elderly gentleman was sleeping on a bedsheet on the floor. He told me that his wife had been there for several hours and that they had been married for 40 plus years. He's never left her side in those 40 years, and that he wasn't about to start now. So really back then, I made a commitment to myself to do everything I can to help our older patients in the emergency department. That wasn't right, and it should not happen.
My mother has been a patient here for almost 25 years now. Because I have a lot of experience running to the ED, I see what happens with staff. They're busy. Someone else is coming in with chest pains. Someone else is coming in that they can't breathe. I see that they're pulled in a lot of different directions. I see sometimes in her eyes when the doctor's speaking to her, her vulnerability. Sometimes her eyes water. She didn't understand what he just said. And I see the fear.
In other parts of the hospital, you have more time to spend with your patients, interact, build relationships. In the emergency department, people are here for a shorter period of time, in a more acute state, with more anxieties, with the fear of the unknown. So it's really crucial in that time that as a healthcare team, for us to be able to really make a difference and have those connections. So they may be very brief connections that we have with our patients, but they can be often the most important connections.
This is shaping future generations of nurses, physicians, and other allied health providers to provide optimal care for older adults.
I was telling someone the other day that working at UHM is like dreaming out loud. I always thought that we needed to have a streamlined way to deal and address the issues of our seniors that come into the ED. I want our patients to have like rapid access to the care that they need, and this will help that.
The world is experiencing a longevity revolution with an extraordinary transition in population demographics. And we all know this, we all see this, and I think we've in Canada all been talking about this for years. Yet emergency departments across the country, which, as I've said, are really the safety net for the system. This is where people seek care when they're at their sickest and where people seek care when they don't have another place to seek it. They remain ineffectively designed to meet the needs of an older population and insufficiently staffed to meet these needs as well. We know that patients, as they're living older, as we're all living older, we do develop more comorbidities. So while we are living longer, we actually tend to be living with more diseases and potentially be suffering from some of the burden of those diseases as well. And so we really need to transform the care across all domains, but for us particularly, emergency medicine care to meet those needs for our aging population. Next. There are some local challenges. You can see that in Ontario, the older adult ED visits grew by about 29% in the period between 2009 and 2014. This is the fastest out of any age group. Toronto is North America's fastest growing city, and it is anticipated that ED visits by older adults will double by 2046. Older adult ED visits have grown by 10% in the past 5 years to be more than a quarter of UHN ED visits. And the expectation is that by 2030, older adults will account for 30% of ED visits. So the numbers are only increasing and increasing very, very rapidly. And when you think that emergency departments were really designed to deal with patients who could walk well, who could come in and come out, or who would come in on stretchers, they were designed for people to be there for a short period of time and to then either be admitted or to be discharged. But we know that patients are staying longer. And we know that patients staying in emergency departments do develop some complications. Next slide. It is a loud and busy environment We know that there is a high risk of dangerous drug interactions because often in the ED, we don't have the full story of what medications people are taking at home and how they're actually taking them, which may not be the way that they've been prescribed. We know that older ED patients stay longer in the ED and they get more tests in the ED, again, contributing to that long stay, and that more of those patients end up getting admitted. The problem is that it's a loud environment. It's an environment where we always have overhead announcements and beeping alarms and people coming and going. And sometimes we have patients who are intoxicated or otherwise altered on substances and who potentially are loud and disruptive. And this is not the kind of environment that leads to a peaceful stay, particularly if you're needing to be there for sometimes 15 or 20 hours while you're waiting for a bed. And we know that patients who are older are at high risk of developing delirium, which is a serious medical condition because of their prolonged ED stays. And we know that older patients who are sent home with delirium have a very high risk of dying within the next month, and that this is something that is often missed and is often actually caused by prolonged emergency department stays. So we need to do better, and we need to do better in many ways. But one of those ways is by building better infrastructure to not allow these things to happen. We know that 20 to 30% of older Ontarians fall every year, and that there are over 300,000 visits to the emergency departments for fall-related issues. We also know that many of those people who fall once fall again. So maybe that first visit to the ED with a fall is where we can put interventions in place to prevent the second and third and fourth fall from happening, so that the fall that doesn't cause an injury is not then leading to the fall that causes a fractured hip or a bleed in the brain. And our hope with this new space is that we can have our colleagues in occupational therapy and physiotherapy assess these patients, help them to get the right supports in their home, help them to get the right aids to be able to walk at home so that they don't fall again. And this is what we can do with a space that allows for more time and a space that allows for more staff to be able to look after these patients. Next slide. So the pillars of this program are really the space that we talked about. So that first dedicated purpose-built geriatric emergency center, which will go at the Western, which has the ambitious opening date of 2023, which is excellent, but we're going to need some more support to make that happen. That the care of the patient is focused, that every step of this journey from the minute they come in serves an older adult's unique needs. Okay, needs for better lighting, needs for safer flooring, needs for safer washrooms to get in and out of. We know, and we've been working already on building a strong community of partnerships, both within our hospital at UHN and with our partner organizations outside of UHN, to improve the transitions of care so that when patients come into the ED, that their primary care provider knows what happened in the ED, that we have appropriate follow-up for them, and that we have bridging follow-up as well to help with the condition that they came in with. And that if there are ways that we can get more supports into the home, that we can allow that to happen as well. And this is another big pillar. UHN is the country's premier research organization. And this is an area where in emergency medicine, we think we can make a huge impact, not only across this country, but in the world. And what we'd like to build is the first center of excellence in geriatric emergency medicine research and education. We have the right people to do it. We have wonderful providers, many of whom have done fellowship training in geriatric emergency medicine. We now need to give them the time and the space to transform this. Next slide. So who will the center serve? It will serve older adults who could benefit most from early multidisciplinary assessments. So these are assessments by our specialized geriatric emergency medicine nurses, by our occupational and physiotherapists, by our pharmacists, in order to have a really comprehensive look at the patient and what brought them to the emergency department today and how we can prevent an adverse event from happening when they leave. So it's everybody all together in a space that is tailored to their needs. We are hoping to avoid admissions to the wards for social issues. So for patients to arrange to have housing, to have home supports coming in, we are hoping to do this directly from the emergency department so that the patients are not getting admitted and then potentially getting deconditioned because they're getting admitted into an already overburdened hospital system, that we can actually tailor their further care in their homes. We are looking at a patient population that is at high risk of falls and delirium and working on how we can prevent this. And we really, really want to avoid those admissions that are at high risk for prolonged hospital stays as well. Not to protect the hospital, but to protect the patients. We know that long hospital stays are not good for anybody. This leads to deconditioning. It can lead to worsening of underlying dementia. And many patients after prolonged hospital stays are not able to get back to their homes. So if we can prevent this, we can allow them to be cared for in the space that they want to be cared for longer. And this really does represent about 30% of the older patients coming into Toronto Western Hospital. Next slide. So the best care for older adults begins here. And so we're turning to our community of donors to build upon our momentum. So that was that lovely, generous donation that we were given to build the physical space. But we think we can do more with more support. So in addition to building this first purpose-built space, we would like to upgrade and renovate the current ED spaces at both campuses. So you saw that beautiful space at Toronto General, but remember that's only half of the emergency department there. That is not the main side of the emergency department. That really does need a refreshing. You can see that there's lots of things in the hallway as you saw those cameras going on, and all those things are tripping hazards. So there's lots that we can do better there to change both emergency departments to make them easier to navigate for older adults, and not just older adults, but other patients coming in with mobility issues. You know, we do focus on older adults, but these things will benefit others as well. We want to advance this area of research. The global field of geriatric emergency medicine is a very, very new field, and we really think that we can lead the way, and that building on UHN's track record of research excellence, that we can actually make ourselves the best in the world at geriatric emergency medicine research. We also would like to create a workforce with expertise in geriatric emergency medicine, that we shape the best practices and the future generations of clinical leaders across disciplines, from nurses to physicians to physiotherapists to pharmacists, to everyone involved in the care of patients, that through educational efforts, that we can make the best providers for older adults from UHN. Next slide. So thank you very much for listening to us today, listening to what we've done and what we hope to do. And I think we're going to move to the question part of the presentation now.
Yes, we are. So thank you, Dr. O'Connor and Deb. It really is great to hear what has been made possible by your team's, incredible insights. And, of course, with donor support, but it's really, you guys are the ones that are making it all happen. And, all of this is to enhance patient care. And, it's really exciting also to hear what is to come. So, thank you to both of you and your teams for the incredible work that you do to look after us all, really. Okay, so yes, now we are going to move to our audience questions via Slido. So we will let's just jump right into it. So from Shoshana, sometimes people are not sure if what they are experiencing requires a trip to the emergency department. A telephone consultation would be very helpful. Will there be one?
So I'm happy to take this. So I am a firm believer that the patient chooses their emergency. We are always happy to see people. Sometimes you have to wait longer if when you come to triage and our experienced triage nurses have assessed and feel that this is something that can wait, but I'm always happy to see people, and I'm always happy to give reassurance if that's all that is needed. However, I do see that some people are not quite sure whether they should come in or wait to see their family doctors or seek care in other places. And that's really what the virtual emergency department was designed for. So as you may have heard, and it is available through the UHN website. You can sign up for an appointment time in the UHN virtual ED, where you will be assessed by a provider. They can ask you questions, they can see you through a video linkage. It can be done by phone as well. And they can let you know whether this is something that can wait for another day, whether it can be dealt with actually virtually, or whether you should head into your local emergency department for a further assessment. So this does actually already exist. And many of our partner academic hospitals also have a similar type of virtual ED. And we're hoping that this can continue to through into the future, provided on, government funding continuing for this type of access. But we have received a lot of positive experiences, or positive response. Mm-hmm.
Yeah, yeah. Sorry.
I was just thinking, I think that maybe asks the answers the next question as well, the virtual access for patients who live far from medical assistance. So you don't have to be a UHN patient, and you don't have to live in Toronto for access to the virtual EDs that you can actually access from anywhere in Ontario. The requirement is you do have to be in Ontario, though.
Okay, so can I ask a follow-up question to that? So how does the virtual ED differ from, say, calling telehealth? Like, why would I do one over the other?
So with telehealth, who you are speaking to on the phone at telehealth is a nurse, and they have specific algorithms. So if you call telehealth and you give certain key answers to the questions that they ask you, they will ask you to call 911. It's very fixed, and it's very formulaic on purpose, because they can't do an assessment. But when you call into, or when you make an appointment with a virtual ED, who you speak to is a provider. So a nurse practitioner or an emergency trained physician. So an emergency trained nurse practitioner or an emergency trained physician who will assess you and ask you the same questions that they would ask you if you were to come into the ED, which gives a more fulsome understanding of the condition. Those of us who are a bit old school always say that the most important part of a medical assessment is the history, and I'm a firm believer in that. It's not the tests we do, it's not the blood work we do, it's actually the questions and the symptoms that the questions we ask and the symptoms that people are having that guide us the right way. And so you are actually getting a medical assessment. And in some cases, actually, if it's something that can be looked at, a physical assessment as well during this visit.
Oh, wow. Okay, that's great. So I think we've dealt with that virtual access for people. Yep. Okay. What do you expect the wait times to be in the emergency room for a patient to see a doctor, and how long until that goal is ramped up and achieved?
Well, what do I expect, or what actually happens, or what would I like to achieve? Certainly, I never want people to wait. And it's interesting, when you hear wait times being reported in the media, there are many different types of wait times. So there's wait times to see a provider. There's the waiting time while your workup is being completed. So while things like your CT scan is being done and your blood work is being done and things are being read. And sometimes there's wait times to see a consultant or to be admitted to the hospital. And all of those have different times. In the emergency department, our whole system is designed on seeing the sickest patients first. The patients who are at risk of deterioration, who are at risk of an acute life or limb or sight-threatening event, have to be seen first. They need the care first. So that always affects the wait time. If you come in and your heart has stopped beating, there is no wait to see anybody. And that's how it goes. If you come in and it's something that can wait safely, it does have to wait until a provider is able to see you. Now, many of the wait times in emergency departments are also affected by things that are outside of our control. So things like when we ask a cardiologist to come and see you, the time for that cardiologist to come down and see you is outside of our control. The time from when you're admitted to when you move up to a ward bed is also outside of our control, because that depends on how busy the hospital is. And if there are many patients in the emergency department waiting for beds elsewhere in the hospital, that does unfortunately have a downstream impact on whether you can be seen. Because of course, if you are coming in with abdominal pain, pain in your belly, I can't see you in a chair in the waiting room and actually do a proper assessment. I need a physical space to see you in. And if all of our physical spaces are occupied by patients who are admitted to the hospital but have nowhere else to go, then you can see that does cause some downstream effects techs. So, and that certainly has happened at both of our emergency departments, and it's certainly something that we don't want, and that we are working with our inpatient partners on coming up with better solutions and strategies for how we can move patients through the ED, but it remains a challenge.
Okay, thank you. From Kate, why is the Rapid Assessment Center so underutilized? I had occasion to use it recently and received brilliant medical care in spotless state-of-the-art facilities. There was only one doc and one other patient waiting, but several not in use medical workstations, yet the emergency room was overflowing.
So I can take this one. We've had to develop specific criteria for patients going to that rapid assessment center, largely because it is far away from the acute area of the hospital, of the department. So we have criteria for patients that are suitable to be managed in that space. And it's largely because of the nursing ratios that we have there. So when we have 40 patients over there, there's still only 3 nurses caring for that large number of people. Is also dependent on the volumes, and the volumes in our department are spread out, of course, across a 24-hour period. And what we find is that the peak volumes for patients appropriate for the Rapid Assessment Center start at about 11 a.m. and then they start to taper off towards 10 or 11 o'clock at night. So if you're there early in the morning, there might not be very many patients there, but over the course of the day, the volume will start to filter in. And I think one of the interesting things for me was when we started to look at what was actually going on in the department with the volumes in our old rapid assessment center, it was almost like there was something that happened at 4 p.m. That we would get a large number of patients who were totally suitable for this area, coming from our local catchment area around the hospital, people that had just come from school, just come from work. And that's when we would see the increase in our volume. So I'm not overly surprised by that. But I think if you're there later in the evening around 7 o'clock, you would see all of the base full and the waiting room full of patients. So we don't control the volumes, and unfortunately, patients come in at their will, right? So, but there are peak times for us.
I understand. Okay, is staff burnout / understaffing still the biggest issue facing emergency rooms and hospitals right now?
Well, that is a very good question. And I don't know if I would say it's the biggest issue, but it's certainly in the top 3. There are many challenges that the hospital systems are facing right now. But certainly understaffing is one of them. And understaffing is really actually as a result of staff burnout. The pandemic years were exceptionally difficult. And there really hasn't been a relief, I would say, after the rest of the world has moved on from the pandemic. The healthcare system is still very much overwhelmed, very much suffering. And you heard Dr. Saba talking about the moral injury that healthcare providers face when they have to deliver care in situations that are not ideal, where they have to underdeliver because of factors that are outside of their control, when they can't do everything that they want to do to help a patient. That does live with you. And those small injuries, those small things build up over time. And many of our colleagues, Deb and I, have seen this with many of our colleagues, both colleagues who have been doing this for a long time and people who have been doing this a short time. Many people have been crushed under the burden of those moral injuries. Mm-hmm. I think that many of our colleagues also feel a bit undervalued when it comes to their remuneration as well. And people are leaving. And it's unfortunate because the people who are leaving also take a wealth of experience with them. Everything I learned as a physician, I learned from experienced nurses I worked with, Deb being one of them as a brand new staff, coming up to her and asking her so many questions. This kind of institutional memory is important to preserve, and we've lost a lot of it. So it certainly is a big issue. Now, the answers for this and how we fix this are really multi-pronged, but it is still very much there, I'm afraid.
Yeah. Okay, I think this may have been sort of answered in the presentation, but I'll ask it again. With the explosion of condos being built in the downtown Toronto core, is anyone considering the impact this will have on hospital emergency rooms? It feels like the city doesn't have capacity to care for the community in terms of basic necessities at the rate it is growing.
So I think just I could say that that was the one thing that triggered us looking for a new space to grow into. And that's why I made it pretty much a project of trying to get people to take a look at that previous space so that we had an opportunity to grow. But I do think that the community is growing. It's the same, hospital's the same as schooling, right? All these condos are going up and there's not enough schools for the children. So I do think that there is an issue, but within UHN and through the donations from our folks, we are very fortunate to have been able to plan for some of this growth. And that space was actually built not just for this volume we're seeing now, but also for the future volume. So we're very fortunate that way. Erin, is there anything else to add for that?
No, I would say that this is something that's very much on the radar of all the downtown hospitals, though. We're all anticipating that we will see increased volumes and thinking ahead to how we can be a bit more creative about how we manage them as well.
Okay, when a patient goes to emergency, what can they bring with them, if possible, to help speed up the process, to help the health system?
So I can take this one. Your OHIP card is the number one thing that we would like you to bring. That's what gets your visit started. If you're on medications, it's really important to either bring a list or bring the medications with you so that we understand what you're on. One of the things we're looking at in the future is having patients maybe do some self-registration using our new Epic tools. So, being able to launch onto My UHN will be very helpful in the future state, but really just come prepared with your medication and your OHIP card and be able to tell the staff up front why you're here to see the doctor and the staff here. So that's what I would suggest for that.
And perhaps a bit of patience too, yes?
You know what?
What I would add as well is bring some things actually to help with your own comfort. Make sure that you bring a cell phone charger, that you bring a book, some magazines, something to watch, something to do, bring a bottle of water, that kind of thing, in order to actually to help to manage some of your own needs while you're there, while you're waiting, would be helpful.
Yeah, great suggestions. Okay, who can use the UHN emergency?
Well, this is an easy one. Anybody. Anybody and everybody can use the UHN emergency. So like all emergency departments, our doors are open to anybody who needs us at any time of the day, on any day of the year. That's what we do.
Love it. Okay, from Jane Mitchell. Does your new process rely on some self-screening by patients coming into the ER? Secondly, when the patient and family do not have a family doctor, will there be follow-up to ensure they do in the coming weeks, months, until they do and are happy with them?
So I think when you're asking about the new process, it's really the registration happening in the new Rapid Assessment Center. And that, to be clear, is registration. You are still triaged by the triage nurse first to determine whether your condition needs to be seen on the main side of the emergency department or whether you could go to the Rapid Assessment Center. And then after that, the registration, so gathering your OHIP card data and where you live and who your family doctor is and all of those things are done. So that self-screening does not need to happen. We still do that through the triage system. When a patient and family do not have a family doctor, will there be follow-up to ensure that they do? So UHN does have a family health team. They do serve a certain catchment area in the downtown, and there are times when they are able to take patients. They do try very hard to take patients, but they are not always able to. We do not have a way to ensure that every person coming into the ED has a family doctor. There simply are not enough family doctors in the Toronto area that we can match people with somebody. Every once in a while, you get a new family doctor opening up a practice and they will deliver business cards to us in the ED, and we will diligently hand those out when patients need them and request them. But we have no formalized way to do this.
Okay. Okay, are there plans to expand the virtual ED concept to other hospitals? If so, which hospitals and when?
So the virtual ED actually has already expanded to many other hospitals. So many of our partner hospitals in the GTA have already signed on to the virtual ED concept. And there are certainly a number of others across the province and across the country who are doing this. I honestly don't know which hospitals and when. This is a ministry level kind of thing. So And I'm just I see another question pop up about the virtual ED. It's actually available if you go to the uhn.ca main page. There is a link to the virtual ED, and maybe if someone is able to access the link and put it in the chat, maybe that would be helpful.
Okay. I think I know the answer to this, but do you treat children in the emergency department?
So it's a very good and very timely question. So yes, we do. We don't often see children because our hospitals are so close to the hospital for sick children, especially at the general. Many patients will preferentially choose to go there. And so, yes, we absolutely do. And it is something that we are capable of doing. We are a little bit rusty. Given the current state of the hospital for sick children, and really, the increase in respiratory viruses that we're seeing in the pediatric population of the province, we are currently, Deb and I, very rapidly working on refreshing ourselves and our staff to ensure that we are prepared to look after children, that we have the right equipment, that we have the right medications, and that we've all given ourselves reminders of those things we all learned long ago. But we are able to do it if people do come.
Okay, that's good to know. And our final question, will you have a social worker designated to this new program?
And I think that probably is the geriatric emergency center, the seniors emergency center. And yes, that is our hope, to have social work dedicated to this area. The staffing has not been fully worked out. It will depend a little bit on funding that we're able to get, but that would be absolutely the goal, realizing the importance of our social work colleagues and how they are able to help so very much with proper transitions from the ED. It's really going to be needed. And so that would be absolutely our goal.
Okay, well, thank you. Well, thank you to all of our attendees for all of your great questions. And thank you again to Deb and Dr. O'Connor. I hope all of you have enjoyed today's behind the scenes presentation. It really is important for us at the Foundation to give you the opportunity to discover how your generosity fuels so much of the work at our hospitals and the impact you are having on people's lives every day. So our next behind the scenes will be held in the spring, so please keep an eye out for your invitation. For those of you who are so inclined, a recording of the presentation will be available on our YouTube, Foundation YouTube page, should you want to view it again or share it with your friends. And once again, thank you to all of you, our donors, for your continued support and generosity. Thank you to Deb and Dr. O'Connor. I hope everybody stays well and stays safe, and we hope to see you again soon. Thanks.